I'm going to go straight away and introduce our speaker for today, Dr. Soner Panchal. So Dr. Soner Panchal is a consultant at Dr. Nagori's Institute for Infertility and IVF at Ahmedabad, India. She is a radiologist who has been doing exclusive obstetric and gynec ultrasound since 1998, and she does dedicated infertility-related ultrasound since 2000. No wonder she can look at the uterus, look at the ovaries, and tell you the hormonal status of the patient. She has herself done her master's in ultrasound in OBGYN from the prestigious Ian Donald Inter-University School of Medical Ultrasound. She is involved with training and teaching of gynae ultrasound since 2012. She has given more than 700 guest lectures at several state, national, and international conferences. She is a professor at Dubrovnik International University, Croatia. She's a national academic director of Ian Donald School, India, where they offer a master's course in ultrasound in OBGYN and human reproduction. She has published articles in various journals and serves as a reviewer for various journals. She is an author of 6 books on gynae infertility and ultrasound in the recent few years, and her special interest is infertility and ultrasound. I do gynecological ultrasound, but if somebody was to ask me anything about infertility and ultrasound, I feel I stand nowhere near the master on this topic, Dr. Soner Panchal. I don't think there are, I don't know if there are any in the world. I'm sure there may be, but I don't know anybody of this caliber, this understanding, this level of understanding of infertility, ultrasound, and sonoendocrinology. Dr. Soner Panchal is not only a great researcher and very, very passionate about her field, she's also a wonderful, open-minded person that I have known for many years. It's an honor to introduce her. A very warm welcome to you, Dr. Soner Panchal. Really looking forward to this talk. I also would like to tell thank the participants who have registered from over 79 countries. I think it might be 80 by now, that have taken time off on their precious Sunday to join in for this talk, but I totally feel it will be worth your time. And if you have any questions, please put it in the Q&A box. We will answer, Dr. Soner Panchal will answer your queries at the end of her talk. A warm welcome to the delegates and doctors who have joined in from various countries, and a very warm welcome to you, Dr. Soner Panchal. It's all yours now.
Thank you very, very much, Dr. Mala, for those very, very kind words. And I think you have probably estimated my caliber. Anyway, I just need to ask somebody to allow me to share my screen. I'm not allowed to do that.
I think she.
Yeah, now I am.
Okay.
Now I am. Thank you. Now I am. Okay, so at the outset, thank you very much to G. Thank you very much to the Gynec Academy for this excellent opportunity to share all my experiences and ideas with you all. And I'm sure it will be of some help, some insight for you, for all those who are practicing infertility, for all those who are doing ultrasound for infertility. So to start with, sonoendocrinology. If we say that word, it's an advanced concept in the management of female infertility. We know that females, infertility is becoming very, very common with the changing lifestyles and the changing environment, etc. The management of infertility consists of various treatments like intrauterine insemination, in vitro fertilization, and intracytoplasmic sperm injection, etc. And all these treatments, they require an ovulation induction. So ovulation induction is common to all these treatments. And this can be monitored by ultrasound or by hormonal assays. to assess the follicular growth as it is occurring with ovulation induction, the way the endometrium is responding, etc. But very interestingly, hormonal changes can be correlated to the ultrasound findings. The hormonal changes occurring during the menstrual cycle first reflect as vascular changes and then as morphological changes. So, any hormonal change that occurs in the female reproductive system, there is first a vascular change occurring in the ovary or in the endometrium or in both, and that is followed by the morphological change. This means studying the vascular changes with Doppler can be a more appropriate tool or more accurate tool for the cycle monitoring. Hormonal assays, when you take a blood sample. So you say, for example, you are assessing a patient in the pre-ovulatory phase. This is a phase where every hour the hormonal profile is going to change. We know once the LH surge starts, it has a sharp rise, and within about 36 to 42 hours, it's from almost zero, it's going to shoot up to maximum, and then it's going to fall. So this is a time which is very, very dynamic. Even if we plan a hormonal assay during this time, you ask the patient to give a blood sample, collect the blood sample is collected, it goes to the lab, the report comes back to you, and you take an action, would take at least 2 hours. And I believe that during this period, the hormonal dynamics is so fast that even if you pass 2 or 3 hours, you have probably missed the train. So that is why ultrasound and a proper understanding of Doppler plays a very, very important role in the monitoring of these cycles. So, using this knowledge of ultrasound to understand the endocrinological changes occurring during the natural as well as the treatment cycle is what is sonoendocrinology, and that's what we're going to discuss. Thorough knowledge of the basic physiology is essential for confident management of the treatment cycles in infertility, and therefore it is of prime importance to first correlate the physiology of ovulation to ultrasound and to the Doppler changes, and then use this knowledge to monitor and modify the treatment cycles. So a very important key message for us all who are into infertility management is that what we know about fertility is too little, keeping its intricate complexity of the hormonal changes and a lot of receptors and a lot of other biochemicals in mind. It is best that instead of trying to control and grossly manipulate the reproductive physiology, it is much, much better. You would get much better results if you understand the physiology and just try to support it with your medicines. And that is where we need a very close observation and understanding of the physiology and its correlation with the ultrasound and the Doppler. Adding volume ultrasound, that is 3D ultrasound, and 3D power Doppler to this may be of more information. If we are talking about ultrasound, what are the modalities that we are going to use? We're going to use B mode ultrasound or 2D ultrasound, which we use to study the morphology of the uterus, ovaries, of course, endometrium, follicle, and the corpus luteum, etc. You do the Doppler, which gives you qualitative and quantitative idea about the blood flow in a particular organ. Qualitative when you are doing your color Doppler or your power Doppler or maybe HD flow, and pulse wave Doppler gives you idea about the quantitative measures or quantitative assessment of the blood flows in these organs. 3D ultrasound gives you more detailed idea about the morphology. It helps you more accurate volume calculations, and 3D power Doppler gives idea about the global vascularity. A simple example, I am doing a 2D Doppler for the endometrium, a power Doppler, and I'm seeing flows only in one plane, which is the mid-sagittal plane of the uterus of the endometrium. But that doesn't give me, though that shows me blood vessels very well, that doesn't give me the actual idea about the global vascularity, which is spread throughout the endometrium, and that I can get an assessment, or I can do that assessment with the 3D power Doppler. So the 3D power Doppler has a very important role to play, though it is still not fully explored and understood by most of our colleagues. If I'm talking about using Dopplers for understanding the hormonal changes, a little bit of uh, attention to the very basics is very much important and required. To get the correct Doppler findings, to make these findings standardized so that the results can be comparable, there can be inter-observer and intra-observer variability. For that, you need to optimize the 2D image as well as the color flows. What are the settings that are important to us? The first is the 2D, and it is apart from a good gain and the contrast setting, it is very, very important to use a proper zoom so that the area of interest, say for example, the follicle or the endometrium, it fills up 2/3 of the image, and the zoom should be that much so that the image occupies about 2/3 of the screen. With large images, tiny structures can be well identified, the morphology can be better studied. And then, when you're using Dopplers for infertility, it's very important that for your power Doppler, for your color Doppler, the PRF, the pulse repetition frequency, must be set at 0.3, and it should be kept at constantly at all times. It must be put into your preset of infertility at 0.3. Of course, for the uterine artery, you may increase the PRF, but otherwise, for follicle, endometrium, and the corpus luteum, it should not be changed. The second important setting is your wall filter, and the wall motion filter must be set at the lowest, because the vessels that we are assessing are very tiny vessels and the wall motion is very scanty or almost absent. These are all very small vessels. So wall filter must be at the lowest for power Doppler and for the HD flow and for the color Doppler. For pulse wave Doppler, you may have to change your PRF depending on the velocity of the flow in a particular structure, but it is very important to set your wall filter at 30 Hz in these cases. The gains of the color should be so set that you would see only the vessels being filled with the color. There should be no spill, otherwise you're going to overestimate the flow. And the balance is the setting which balances the visibility of the 2D and the color, and the balance setting should be optimally adjusted so that there is no compromise on the evaluation of the 2D when you're trying to see the colors, or the other way around. So these are the important settings that you have to do before you start doing your infertility scans to evaluate the endocrinology, and even to evaluate your even to monitor your site treatment cycles. To simplify the complex physiology of reproductive system, we would just classify the entire discussion into 3 phases of the cycle: the baseline scan, which is the early proliferative scan, usually done day 2 or 3 of the cycle, the pre-ovulatory scan, and the luteal phase scan. Before we start this discussion, let's a quick mindful look into the hormonal changes. And that is where I really want to draw your attention. For all my radiologist or sonography specialist friends, we are usually not very used to correlating the reproductive physiology with the ultrasound findings. And that is where we are missing the diagnosis. So just a quick look to this. Remember that at the start of the cycle, day 2 or 3 of the cycle, the FSH, LH, estrogen, progesterone are all at their almost baseline levels. It's just before the mid-cycle that the estrogen rises to the peak. With that peak, just before that, the LH surge starts. As the LH surge reaches the peak and falls, that's where the estrogen falls, and the progesterone actually starts rising soon after the LH surge starts. So this is, and immediately after the ovulation, the estrogen, progesterone, both are low. The progesterone is still rising. The estrogen is falling. This is the phase of the cycle where estrogen, progesterone both low. Gradually, the progesterone increases and it reaches a plateau in the mid-luteal phase, and then again falls before the cycle. Almost same to a little lower extent, but also happens with the estrogen. So it's estrogen, progesterone, both, which are required in the luteal phase also. So that is just a quick overlook onto what we are going to observe with our ultrasound. And now, coming to the first phase of the cycle, the baseline scan, day 2 or 3 of the cycle, and that is when there are majority of the hormones that we want to check. We want to check FSH, LH are both at their baseline, estrogen, progesterone are both at their baseline, but there are other 2 hormones which are important to us, and that is androgen and AMH. Of course, androgen and AMH do not have a huge variation throughout the cycle, but still, whether low or high, they are going to affect the ovulation. They are going to affect the effect of the ovulation induction drugs, and therefore we need to understand their levels also. We need to assess their levels also. And of course, there are other 2 hormones, thyroid and prolactin, though we are not going to discuss these 2 today. And the last one, which is not truly a hormone, but still this biochemical assessment is very important, and that is insulin resistance. So these are the things that we are going to assess: androgen, AMH, FSH, LH, estrogen, progesterone, and insulin resistance. What would the ultrasound say about these things? Would it say anything? Would it give us any information? Yes or no? Let us start with the first one, and that is androgen. Androgen, as we know, it is produced from cholesterol in the theca cells under the effect of LH. It is produced also from the adrenal gland. It is this androgen which is responsible for the recruitment of the follicles from the pre-antral stage to the antral stage follicles. And it is this androgen which also sensitizes the follicles to FSH. Very interestingly, though androgen is responsible for the recruitment of the follicles from pre-antral to antral, under the effect of androgen alone, these follicles can only grow up to 6 to 7 millimeters, beyond which they become FSH sensitive, of course, with the courtesy of androgen. And after they reach a size of 9 to 10 millimeters, that's when they become FSH dependent. That means that the presence of antral follicles tells us about the presence of androgen. If the androgen is high, there are more antral follicles. There are more follicles recruited from pre-antral to antral as it occurs in PCO patients. So you can just scroll across the ovary, eyeball, and look at the abundance of the antral follicles, and that gives you idea as to the androgen level is high or not. The androgen also reflects as high uterine artery resistance as seen in this picture. What do we mean by high uterine artery resistance? You know that when you're doing a transvaginal scan from the mid-sagittal plane in the longitudinal section, as you span your probe from the mid-sagittal plane laterally towards the lateral pelvic wall, you will see the entire contour of the uterus, and then at a point you will lose the vision of the uterus. But before you do that, close to the lower end of the uterus, you will see a tubular structure, serpentinous tubular structure entering into the uterus, and this is the uterine artery, and that is where you would measure the uterine artery flow. Mind you, it must be measured before. You will see multiple loops, but it must be, you can measure it in any part of the loop, but before it bifurcates. That's where you measure the uterine artery flow. And I said it is a low, it is if the androgen is high, it's a high resistance flow. How do I identify a high resistance or a low resistance flow? Of course, quantitatively, we can assess the resistance index or the pulsatility index. And a high resistance index where the RI is more than 0.6, 0.65, we would say it is a comparatively or a moderately high resistance. When it's more than 0.8, we would say it's a truly high resistance flow. Whereas in the uterine artery, we usually measure PI, the pulsatility index, and when the pulsatility index is more than 3, that's when we say it's a high resistance flow in the uterine artery. But that is quantitative assessment, and I'm not going to go into the details of how it is calculated because the machine can do it for you. Once you have located the uterine artery, you can switch on your pulse wave Doppler. You can place your sample volume onto the uterine artery flow, and you would get a spectrum. Even if you don't go to the quantitative assessment, just by looking at the spectrum, you can make out whether the flow is a low resistance flow or a high resistance flow, and that is also quite sufficient for us. It's not always essential to take the exact measurements, to take the exact quantitative assessment of these resistance as far as the baseline scan for the uterine artery is concerned. Of course, I'll tell you when the exact measurements are required. So, on this spectrum, we know that this is the systolic peak, that is the diastolic flow. So, if the diastolic flow roughly is less than 1/3 of the systolic peak, we say it's a high resistance flow. Whereas the diastolic flow is more than 50% of the systolic flow, that's when we say a low resistance flow. So, it's a high resistance flow which is seen in the uterine artery by the effect of androgen. And why is that so? Remember, apart from the recruitment of the follicles from pre-antral to antral, androgen has one another function, and that is increasing the smooth muscle tone. Androgen, which is popularly known as the male hormone, it increases the smooth muscle tone, and it is the uterine artery which has a thick muscular layer. It has a thick muscle layer, and the tone in this muscle layer increases as the androgen level increases. If the tone in the muscle increases, with the cardiac systole, there is a push of the of the blood. There's a gush of the blood in the artery, which gives us the systolic peak. But whenever the heart is relaxing, it's in the diastole. That is where, because of this increased tone in the muscularis, it will not freely allow the blood flow, and therefore the systolic flow significantly decreases, and therefore androgen leads to high resistance flow in the uterine artery. So the androgen has two effects: one, recruitment of the antral follicles; two, increase in the uterine artery resistance. High androgen is the cause of AFC in the PCOS. The axis of ovarian follicles in the PCOS is strictly associated with hyperandrogenism, and this has been demonstrated by Diwali et al. Why does androgen lead to increased AFC? And why does the entire vicious circle keeps on going once the PCOS patient starts manifesting the disease? Now, that sentence itself is important. It has a lot of messages in it. I told you that once the patient starts manifesting, after that, the number of antral follicles starts increasing. And after that, there are other changes also going on in the ovary. And if we put them all in a very simple fashion that a non-endocrine specialist may also understand, it goes this way. We know that PCO, which is basically an insulin controlled, or it starts from the insulin derangement, insulin metabolism derangement. Whenever there is hyperinsulinemia, it leads to increased androgen. Increased androgen leads to recruitment of more antral follicles. More antral follicles, their granulosa cells produce more estrogen. So cumulative estrogen is increased. This increase in the cumulative estrogen naturally has a positive feedback on LH and negative feedback on FSH. So the LH increases. As the LH increases, LH function, LH acts on the theca cells for their proliferation, and not only proliferation, production of androgen into theca cells from cholesterol. So LH leads to increase, and the theca cells is the main component for the stroma. So LH leads to more stromal cells, that is theca cells, that leads to more production of androgen, that leads to further proliferation of theca cells and stromal cells, and this leads to stromal abundance. So it is more insulin, more androgen, more follicles, more estrogen, more LH, more androgen production, again more follicles, again the entire vicious circle goes on. So once the insulin level gets increased, once there is derangement of the insulin metabolism, that is when the PCO patients, they start manifesting it's themselves. Not in all the cases. So there are a lot of patients who have genes of PCOS. They do not manifest at all times in their lives, and not all the patients would manifest. I mean, many patients would not even manifest themselves if they control their lifestyle well, even the entire lifetime. So it is very important that the androgen, even in the PCOS patients, rises only with certain triggers, and that is in the insulin derangement. Now, we also know that the PCOS patients in whom the androgen is high, the antral follicle count is high. In spite of high antral follicle count, and in spite of the fact that they produce a lot of follicles on ovulation induction, they still have a lower pregnancy rate. And what is the cause of this? If I have more eggs, I would expect better pregnancy rates. But in PCOS patients, in spite of higher yield of the ova in your IVF cycles, you achieve lesser pregnancy rates. The reason there is into both, into the uterus and into the ovaries. There are more antral follicles, but the LH in these patients is high, and it is this high LH which may either lead to an ovulation, and even if it doesn't lead to an ovulation, it leads to exposure of the follicles, early exposure of the follicles to LH, which leads to bad quality follicles and therefore leads to lower pregnancy rates. On the other hand, we know that it is the same androgen which leads to increased uterine artery resistance, and therefore it leads to low endometrial flow because the branches, if the resistance in the main vessel is high, the resistance in the branches is also going to be high, and therefore it leads to less development of estrogen receptors, one, and two, it also leads to advancement of the endometrium because there are multiple follicles, more cumulative estrogen, progesterone also starts rising earlier, and therefore advancement of the endometrium and therefore implantation failure. So the basic culprit for the female patients for all their complications is androgen. We just need to find out the androgen is high or low, and that can be done by your ultrasound, increased uterine artery resistance, and more number of antral follicles. Of course, LH follows high androgen and insulin precedes high androgen. If we have to therefore count the antral follicles, as I told you earlier, you can just scroll across the ovary on your 2D scan, eyeball, and count the number of follicles. But this is not quite an easy job in PCO patients because they have multiple follicles. According to new definition, now there are more than 20 follicles in many cases. And in these cases, in this condition, it is best to use 3D ultrasound with sophisticated softwares like Sono AVC to count the number of follicles. The number of follicles larger than 12 millimeter on the day of oocyte retrieval correlated significantly with the AFC counted by 3D ultrasound rather than by the 2D ultrasound. The inherent intra and inter observer variation seen in measuring the number of antral follicles can be reduced by the use of 3D ultrasound and more recently automated ultrasound Sono AVC because you are not overcounting the follicles because Sono AVC gives us a color coding, and with color coding the number that there can never be an overcounting of follicles. There's a short video of how to use Sono AVC. You have acquired the volume of the ovary. Now you move to volume analysis, and then you select Sono AVC, and then you just press on either right ovary or left ovary, and the calculation starts. All the anechoic areas are outlined by different colors, and on the rendered image, on the last fourth image, you will see all different color solid balls. If it is an oversizing of the follicle, you can cut them. As you saw here, you will see one here also, and it will so you can cut it like this, and then you can remove the extra part. So that is cutting. If there are two follicles which are if there is a single follicle which is measured as two follicles, you can merge them, you can add or remove the follicles, and that is how you can ultimately come to the correct assessment of the follicles. You can do this procedure moving from one plane to other plane. So you walk through, and in every plane you do the post processing, and at the end of the entire thing you would see the resultant image, which shows the number of follicles, all color coded, perfect sizes, and on the result sheet you will see them as X diameters, Y diameters, Z diameters, and you'll also see the volume of each and every follicle. So that gives a perfect idea fewer antral follicles are evident overall. When Sono AVC is used to analyze the 3D ultrasound data, and it is significantly quicker than the 2D ultrasound in making the measurements also. Automated 3D measures do provide reliable information on the follicle number and size and can be used to individually identify each follicle and appear to be more reflective of ovarian reserve and response, but their accuracy needs to be determined by further work, and that is because the post-processing, which requires a learning, which has a learning curve. So 3D ultrasound with Sono AVC is a very good method to count the antral follicles, especially when they are multiple. If they are less, 2D or 3D doesn't make a difference. But when we're talking about the PCO, it's usually more. And therefore, 3D is better. The total yield of the oocytes that you get on the oocyte retrieval would be 60% of the total number of antral follicles calculated. So you are very sure about your yield with the 3D ultrasound. But antral follicle count, you don't only count for diagnosis of PCO or to judge the androgen. You also have to decide what is the ovarian reserve and the response, and what should be your ovulation induction protocol. And for that, again, you need antral follicle count and the ovarian volume to assess the ovarian reserve. Of course, it is a very popular practice to assess AMH, anti-Mullerian hormone, for the assessment of, for the judgment of the ovarian reserve. But AFC also is a strong marker of ovarian reserve. So do we need to measure AMH also, or AFC is enough? What does the literature say? Serum AMH levels have been shown to strongly correlate with the number of antral follicles. Relationship of AMH when was compared with other markers of ovarian reserve, and AFC, serum AMH, correlated more robustly with antral follicle count rather than all the other hormones like inhibin B, E2, FSH, and LH on day 3, which are all used for assessment of the ovarian reserve at different points of time in different studies. If we are talking about a poor reserve ovary and assessment of the ovarian reserve, do we need to measure AMH there, or AFC should be sufficient? The literature says for prediction of poor ovarian response, a model including AFC plus AMH was found to be almost similar to that of using AFC alone. Poor reserve AFC alone gives the same information as AFC plus AMH. A meta-analysis has shown that AMH has at least the same level of accuracy and clinical value for the prediction of poor response and non-pregnancy as AFC. That means for that meta-analysis, AFC is considered even superior to AMH for all the poor reserve patients. If you're talking about the hyper response, both AFC and AMH are accurate predictors of excessive response to ovarian hyperstimulation. Hyperresponse PCOS patients, AFC was highly sensitive in all the phenotypes and was the single best criterion assessed for all the subjects, suggesting an important role of ultrasound. We have done one study where we compared the normal or the control group with the PCO group for assessment of the ovarian reserve by AMH and AFC both. And we saw for two end results: one, number of oocytes retrieved, and two, the number of follicles larger than 12 millimeters on the day of oocyte retrieval. All of us who are into infertility practice, we know that all the follicles up to 12 millimeter in size on the day of oocyte retrieval are likely to give us fertilizable ova. So, comparing the two groups for the two markers, for the two end results, did not show us any significant difference in the accuracy of the two markers for the assessment of the ovarian reserve in the individual group, and therefore, since then, we are using only AFC as a marker for the ovarian reserve. The two do not give any mutually exclusive information, and the reason is strong because AMH is produced from the small preantral, large preantral, and the small antral follicles up to 10 millimeter in size. And therefore, it has to correlate with the AFC, and therefore AFC and AMH have a close relation. Even if you do an AMH, you are still going to do an AFC before you start your ovulation induction to rule out possibility of cysts, to rule out other abnormalities. And therefore, why not use only AFC? AMH is required only in extremes of situations, not regularly, not routinely. Putting, therefore, all this together. So far, what we have discussed, androgen and AMH. Androgen is the cause, AMH is the result of antral follicles, and therefore both have to correlate perfectly with the antral follicles. And therefore, if you are doing your antral follicle count correctly, you actually do not require to do androgen or AMH assays. Coming to the third one, and that is follicle stimulating hormone. A hormone secreted from the pituitary stimulates follicular growth and granulosa cell growth, granulosa cell proliferation. We all know about the two-cell, two-hormone theory. FSH, X on granulosa cells, produces estrogen. LH, X on theca cells, produces progesterone, and this is the most simplest form of the very complex two-cell, two-hormone theory. Talking about the FSH first. FSH was used earlier for the assessment of the ovarian reserve, and it negatively correlated with the antral follicle count. Of course, if we say that FSH is high, the patient's ovary is aging, and therefore the antral follicle count is going to be low. A high day 3 FSH is highly predictive of poor ovarian reserve and the poor pregnancy rates. But it has already been proved long back that antral follicle count is a better marker than FSH for the selection of all older patients with acceptable pregnancy offers, and therefore once AFC came into practice, FSH is not routinely used as a marker for ovarian reserve. But we already mentioned very early during this presentation that after the follicles reach a size of 6 to 7 millimeters, that's when they become FSH sensitive. And beyond 9 to 10 millimeters, they become FSH dependent. It is known that the FSH receptors are not present in preantral and the small antral follicles, but the growing of the follicles beyond the antral indicates the presence of FSH. That means if I see that the follicle has been recruited early, we know that normally the dominance of the follicle is selected by about day 5 of the cycle, and it becomes evident on ultrasound about day 5 or latest by day 7. But you're doing a baseline scan, you're doing a scan on day 2 or 3 of the cycle, an early proliferative scan, and you see a follicle of 10 millimeter, 11 millimeter. That is called early recruitment of the follicle. This suggests that the basal FSH is high. Without that, the follicle cannot grow beyond the size of 7 millimeters. and especially not beyond the size of 10 millimeters. Up to from 7 to 10 millimeters, it has a gray zone where androgen also may act a bit, and the FSH sensitivity has also started. But beyond 10 millimeters, it's only FSH. So if you see an early recruitment of the follicle, it is a high basal FSH. But many times you see a larger follicle on day 2 or 3 scan. Is it every time a high FSH? Yes. If it is an early recruited follicle, it is high FSH. But if it is a residual follicle of the previous cycle, it is not high FSH. So how do I know that it's a freshly recruited follicle or it is a residual follicle of the previous cycle? Very simple. It has been known that as soon as the follicle selects its dominance, the blood vessels are diverted towards these follicles, and very interestingly, they are so clearly diverted towards that particular follicle that the surrounding follicles, they start getting lesser flow and they start regressing. So if you have a follicle of 10, 11, 12 millimeter on day 2 or 3 of the cycle, put on a Doppler. And if you see blood vessels around, if you see a vessel directed towards that follicle, which means it's an early recruited follicle, and which means it's a high pixel FSH. But if you see no flow, that means it is a residual follicle of the previous cycle. It's not hormonally active because it's not showing any flow, and it will not come in the way of your stimulation. Follicular growth beyond dominance is FSH dependent. Normal growth rate of the follicle once it reaches dominance is 2 to 3 millimeter a day. And beyond the baseline scan, when you are seeing, when you're observing, when you're monitoring your follicular growth by ultrasound, if the follicle does not grow at this rate, which has already reached dominance, that means your FSH is either low dose or it is ineffective because of either low bioactivity of FSH or because of polymorphism or because of the receptor defect. And in these cases, you will have to change the stimulation protocols. Excuse me. On the other hand, if the follicle is growing faster, which is again not a good sign, which means the follicles are hypersensitive to FSH. And this is where you'll get a poor quality follicles. We all have observed that patients who have low reserve, patients whose ovaries are aged, they not only have less central follicles, but they also have shorter cycles because they have high basal FSH. Very early in the cycle, their follicles become dominant, they start growing, and therefore they ovulate very early, day 7, 8, 9, and therefore they have shorter cycles. Normal follicular growth rate indicates adequate levels of FSH. The third one is the luteinizing hormone. And the luteinizing hormone acts on the theca cells. Again, the same two-cell, two-hormone, two-gonadotrophin theory. And LH is responsible not only for proliferation of the theca cells, but also for the conversion of cholesterol to androgen and also to progesterone or androgen to further estrogen. So this entire process is in control of the gonadotrophins LH and FSH. LH, as I told you, I repeat, is responsible for the proliferation of the theca cells, and it is these theca cells which is main component of the stroma, as we discussed earlier also with the PCO androgen. This means that increased stroma may be the effect of LH, and it is particularly so in PCOS patients. To revise and to emphasize what we discussed earlier, once again, it is hyperinsulinemia which leads to hyperandrogenemia. And how? A high insulin affects the ovarian tissue because of the insulin like growth factor 1 receptors in the ovaries. Insulin induces hyperandrogenism by increasing 17 alpha hydroxylase activity, decreasing the aromatase activity, increasing LH secretion, and decreasing the synthesis of sex hormone binding globulin, and decreasing the insulin like growth factor binding protein. There are a lot of there are a lot of processes which are occurring as an effect of high insulin, but very important to us are increasing our 17 alpha hydroxylase activity, decreasing the aromatase activity, which keeps on, see, from androgen aromatase, aromatization leads to estrogen, but if that doesn't occur, the androgen keeps on rising and increase in the LH secretion. So these first three are very important to us. It is also the genetic basis which is important for hyperandrogenism caused by hyperinsulinemia. There is increased activity of cytochrome P450C70, which is a catalyst for the biochemical synthesis of ovarian and adrenal androgens and is determined by CYP17 gene located on 10q24.3. So, the high androgen, because of high insulin, has genetic basis. It is because of high LH, it is because of less aromatization, so there is no conversion of androgen to estrogen, and because of high alpha 17 hydroxylase. Moreover, it's also interleukin. Patients with PCOS, interleukin 8 and interleukin 1 in the ovarian stroma are underexpressed. It is interleukin 1 which actually inhibits LH stimulated androstenedione production in the theca interstitial cells. And because this is underexpressed, therefore this aromatization does not occur. The androstenedione production in the theca cells is therefore increased. So, forgetting about interleukin, forgetting about the genetics, forgetting about the complex mechanism, let us once again make it simple. And the simple explanation is here. It is high insulin in PCOS because of genetic interleukin, because of lack of aromatization, because of increased 17 alpha hydroxylase, and because of LH secretion will lead to high androgen. More androgen, so more recruitment of the follicles from preantral to antral, which will lead to more estrogen production, a little bit of estrogen from multiple follicles, their granulosa cells. This high estrogen leads to less FSH and more LH. It is LH when the follicles are exposed to more LH before their maturity. That's when the premature luteinization occurs. That's when the granulosa cells, they convert to theca cells. And the follicles, because the FSH is prevented, do not progress to maturity. Instead, they go into atresia. The granulosa cells, which have got converted into theca cells, they contribute to the stroma. And therefore, there's follicular atresia and theca cell proliferation. And ultimately, it is in these theca cells that further more androgen is produced from the cholesterol, and the entire vicious circle goes on. This repetition is purposeful to make the entire physiology, which is very complicated, easier and put into the proper cycling for interpretation of ultrasound for the hormonal ladies. And there's a literature proof to that. Insulin augments allele-stimulated androgen production by stromal cells, and androgen in turn causes proliferation of the stromal and the theca cells, and these leads to increased stroma in the PCOS patients. This increased stromal abundance, is a very important feature for diagnosis of PCOS. It is a very strong feature which tells you LH is high. And how do you assess that? The stromal abundance, in the most simplest form, can be assessed as the echogenicity of the stroma compared to the echogenicity of the normal myometrium. Normally, the ovarian stroma is equally echogenic to the myometrium or lesser echogenic than that. If it's more echogenic, which means the stroma is abundant. But that is too subjective, and an objective assessment of the ovarian stroma can be done by assessment of the ovarian area or the stromal area. And this is to be done in the strict longitudinal section of the ovary. You draw the circumference and the machine calculates the ovarian area for you. And if it's 5.5 centimeters square, it has a high sensitivity and specificity for the diagnosis of PCO. But this ovarian area is just a surrogate for the assessment of the stromal area. To measure the correct stromal area, you will have to deduct all the follicular areas from the total ovarian area, and that will give you the stromal area. And the stromal area of 4.6 centimeters square has again high sensitivity and specificity for the diagnosis of PCOS. But there is a subjectivity still there. And what is this subjectivity? We know that the section selected, though it's a strict longitudinal section, might not be the same for all. There is a lot of inter-observer variability, and in every different section, even the cross-section of the follicle is going to be different, and therefore there is a chance of error at the measurement of the ovarian area. There's a chance of error at the measurement of the follicular area also. So to divide this error, we can take a ratio of the stromal area to the total ovarian area. And if this ratio is measured and with a cutoff of 0.34, it has been proved to have 100% sensitivity and specificity for the diagnosis of PCO. But this is a small sample. A multicentric study also agreed that stromal area to the ovarian area ratio is a very reliable parameter, but put that cutoff at 0.32 instead of 0.34 and is an acceptable upper limit for normal. If the stromal area to the ovarian area ratio is higher than this, it is a polycystic ovary. But total ovarian volume and the stromal ovarian volume during the early follicular phase are the most reliable ones, because there you are doing a 3D measurement for a 3D structure. 3D ultrasound has a potential to address these points and improve the sensitivity and specificity of the ultrasound in the diagnosis of PCOS. And this can be done by using 3D ultrasound. You take a 3D volume, and then you use what is called vocal to calculate the ovarian volume, and then you use what is called a threshold volume, just the threshold, so that the pigment fills up only the follicles and clearly discriminates between the follicular areas as below threshold and stromal area as above threshold. And it is on that box that you get the stromal volume and the percentage of stromal volume against the total ovarian volume, and the stromal volume of more than 75% in an ovary which is at least 6 cc or has at least 10 follicles is PCO. And it is this stromal abundance which is very important for the diagnosis of PCOS, because it correlates to all the biochemical derangements of PCO. Stromal area to the ovarian area ratio has the strongest correlation with serum androgens, especially testosterone and androstenedione and insulin. Stromal volume was positively correlated with the serum androstenedione concentration in the patients with polycystic ovarian syndrome. Degree of insulin resistance can be correlated with the ovarian volume and the stromal echogenicity. And in one of our own studies, we could correlate the insulin levels in PCO patients very closely with the PP insulin levels, which is the first level to rise in all cases of insulin resistance. And therefore, we proved that if the PCO patient has high stromal volume, she is likely to have insulin resistance. So the cause of more stroma is high LH and chronic anovulation, but it can also be correlated with androgen excess and insulin excess and all the deranged biochemicals associated with PCOS. Moreover, it is elevated LH which is also responsible for increased vascularization in the ovarian stroma. This is because LH leads to neoangiogenesis, so more blood vessels, and it also leads to catecholaminergic stimulation and leukocyte activation, leukocyte cytokine activation. That means it also leads to lower resistance flow. This means that low stromal RI means more vascularity, means high LH. Because of high LH, all the PCOS patients have lower stromal RI, where the RI is always less than 0.58. And on the other side, if the stromal flow is more, the patient is going to respond better to the IVF treatment, to the ovulation induction treatment. Higher the stromal PSV after pituitary suppression, better is going to be the ovarian responsiveness. And those who had low stromal PSV in the early follicular phase were poor responders. In another study, Kupacet has also shown that the stromal FI, the flow index, which indicates the average intensity of the flow in the 3D Power Doppler, if these levels were low, the patient was a poor responder. Between 11 and 14, she was a good responder. More than 15, she was a risk of OHSs. And our experience and the literature review has also shown that hyper responders have lower RI and higher PSV. Normal responders have an RI of between 0.6 and 0.7 and PSV between 5 and 10. And poor responders have RI of more than 0.7 and a PSV of less than 5 centimeters per second. And it has also been shown in one another study that if you do a 3D Power Doppler, you get a correct idea about the global vascularity of the PCO patients, and the vascularity index VI, which says about the average abundance of the flow, in the globe, and VFI, which tells about the perfusion, are definitely higher in PCOS patients. Because this vascularity is higher, therefore there is higher chance of hyperstimulation, because more gonadotrophins are released, are delivered to the ovary in percentage of what is loaded into the patient's system, and therefore there is a higher risk of OHSs. So there are two important things here: LH, stromal flow, and the ovarian response. So how do these correlate? If there is a low resistance flow in the stroma, which means that the patient is going to respond well to stimulation, which also means that the LH is high, that means LH supplementation for ovulation induction is not required in these patients. On the other hand, if the ovarian stromal flow is low, if the resistance is high, which means not only the patient is a poor responder, but it also means that the LH is either low or is not perceived by the ovary because of low bioactivity or because of polymorphism. And it is in these patients who require LH supplementation. And that is exactly what is also told in the Poseidon group 1 and 2, that if the ovarian reserve parameters are normal, whatever the age, but the response is poor, that is where you need to add LH. Because the response is not evaluated in this, the response which is evaluated by the blood flows, the Dopplers are not done. Therefore, we have to wait for a cycle to show us a poor response and then add LH. If we have assessed the flows from the beginning, we know that these are the patients who would require LH supplementation. Mala, you want me to stop here?
No, Sonal, you said after estrogen, right? Or you want to stop now?
You want me to?
No, you can go ahead.
Okay, thank you.
After estrogen means.
Thank you. So the total ovarian vascularization index, VI, and the vascularization flow index are low in patients who are aged. So we know that if the flow to the ovary is less, RI is high, PSV is low, or the vascularity index and the flow index vascularity flow index are low, that means LH is not perceived, LH has a low bioactivity or has polymorphisms. We have to supplement LH, and we have, on the other hand, clinically seen, all of us, that it is aged patients who require LH supplementation. And this has a proof into ultrasound. And this is Poseidon group 2 and 4. In the patients with endometriosis, there also we suspect that these are the patients who are going to respond poorly. And that is also where, if the stromal flows are good, the response is going to be good. If the stromal flows are less, the response is going to be poor. Quantification of the ovarian stromal flow by the 3D Power Doppler ultrasound in women with endometriosis may provide important prognostic indicator in those undergoing IVF. So we have discussed about AMH, androgen, AMH, FSH, LH, and we are going to estrogen. Granulosa cells of big antral follicle.
Sonal, I just realized maybe better to take a 2-minute break, because I realized the time wise.
That's why.
Okay.
So, thank you.
So you can tell them to wait because there's so much more.
Yeah. So what we are going to do is we are going to take a small break here. And after that, we are going to start within 2, 3, 4 minutes. We are going to start again to finish up the entire presentation. Thank you.
Thank you, Soner. You can stop the screen sharing.
Hello everyone, I'm Sonia Alvarez from Gynecology Academy. I would like to brief you about the training our academy offers. Gynecology Academy offers online training in the fields of fetal medicine, infertility management and gynecological ultrasound. The courses offered by Gynecology Academy are complete certification courses in fetal medicine, which is of a duration of 12 months, gynecological ultrasound and infertility management, both of which are of a duration of 6 months. In these courses, you will get access to lectures covering all aspects on that subject. There are 3 types of certifications available. Certificate of participation, where you will get access to the lectures and you have to do the self-assessments after every lecture. Certificate of completion, in addition to the lectures and self-assessments, you will have to submit images. Certificate of competence is in addition to the above, you will have a written exam at the completion of the course. We also have short-term courses in fetal medicine like first trimester ultrasound, fetal growth, etc. In addition, we have individual lectures and modules that can be purchased from any of the above 3 courses. Our courses provide comprehensive coverage of all the topics. In addition, you can submit queries on any of the topics and our faculty will answer them. The access to the web lectures is very smooth and easy to operate, provided your internet connection is good. If at any time you require any assistance, our support team is prompt and courteous. The highlight of our courses are the faculty, who are not only experts in their field, but are also known to be passionate teachers. The faculty for the fetal medicine course are Dr. B.S. Ramamurthy, Dr. Lakshmi Ravi Selvaraj, and Dr. Bijoy Balkrishnan. Dr. B.S. Ramamurthy is the course coordinator. He's a consultant radiologist with 34 years of experience in fetal medicine and has recently authored a book on the fetal nervous system, which has been very well received internationally. Dr. Lakshmi Ravi Selvaraj has 20 years of experience in the field. She is not only a passionate teacher but an avid researcher as well. She has published and presented her work in many international forums. Dr. Bijoy Balkrishnan is a gynecologist with 13 years of experience in the field of fetal medicine. He heads the Fetal Medicine Fellowship program at his hospital. He is well known for his capacity to teach complex matters in a very simple manner. The faculty for the Infertility Management course are Dr. Soner Panchal and Dr. Chaitanya Nagori. They are well known for their abundant research in the field of infertility and for the books they have published on the topic. They are also known for their teaching programs that they run at their center. The Gynecological Ultrasound course is our flagship course. The faculty are Dr. Mala Sibyl and Dr. Sonal Panchal. Both the doctors have over 2 decades of experience in gynecological ultrasound and have published articles and books. Dr. Mala Sibyl is also an ISWOG International faculty member and conducts IOTA courses. She has trained over 1400 doctors over the past 2 years. She has published articles in many journals and is the author of the book Ultrasound in Gynecology, published by Springer in 2017. Online training has many advantages. Mainly, you can access the lectures at the comfort and safety of your home, which is a great advantage, especially during these challenging COVID times. You do not have to leave your workplace or your family while you learn. You can also learn at any time as per your convenience. It can be late at night after all your work is done. You can learn at your own pace. You can pause a lecture, take a break, grab a cup of coffee, and get back to the lecture. You can also go through the lectures multiple times during the duration of your course. One of the biggest advantage of online training is typically during live talks the time is limited, but there is no time limit in online training given to the faculty for any talk, and so they have taken extended time to explain all the aspects of various topics in great detail. You will have several years of work and experience of the faculty for learning. We have received glowing testimonials for our various online courses. You can view more testimonials about our Gynecological Ultrasound course, which is our flagship program, on our website www.gynac.org. The other 2 courses have recently begun.
Gynecology Academy is happy to announce a special Mother's Day discount offer of Rs 10,000 on the Fetal Medicine course and Rs 5,000 on the Gynecological Ultrasound course, as well as the Infertility Management course. So register soon in order to avail this amazing opportunity to learn the best from the best while being in the comfort of your home.
Thank you very much for your time. If you have any queries, you can get in touch with me. I will share my contact details in the chat box below. I hope you enjoy the rest of the webinar. Thank you.